Good afternoon, and thank you so much for joining our podcast today. Race Today is a 1-hour talk show about racism in the United States, as well as an activist program to eradicate racism across the US. I'm Dr. Alicia Williams, one of the podcast co-producers, and I also have my colleague here as a co-producer, Lisa.
Hello, everybody. Thank you for joining us today. We will be discussing another relevant topic that we are facing in our country. Today it will be about intergenerational racial trauma.
Thank you, Lisa. So today, again, as Lisa mentioned, we will be talking about intergenerational trauma in the Black community. So we have a panel of experts who will be able to share their insights with us today, and I'd like to begin with brief introductions. First, I have Leah Mills Chapman.
Hello, thank you so much, Lisa and Alicia, for allowing me to be on your podcast today. My name is Leah Mills Chapman. I am a clinical therapist with a specialty in trauma. Thank you again for having me.
Thank you, Leah. Next, I have Deandra. Oh, you're on mute.
All right. All right, I'm really happy to be here. So hello, everybody. My name is Deandra Wilkins. I am a registered art therapist.
Thank you. Nice to have you, Deandra. Next, I have Lataya Hawkins.
Thank you again for allowing me to be a part of this discussion today. My name is Lataya Hawkins. I am a Lieutenant Colonel in the Army. I'm an LCSW social worker. And I also just recently obtained my PhD in social work from the University of Texas at Austin. My specialty is moral injury.
Thank you, Dr. Hawkins. Nice to have you. Next, I have Dr. McCarter.
Hello, thank you so much for having me. I'm Dr. Safia McCarter. I'm a licensed naturopathic physician and licensed acupuncturist based in Maryland.
Nice to have you, Dr. McCarter. And last but not least, we have Keith Jones.
Hello, everyone. My name is Keith Jones, and as stated, I am a fully licensed clinical therapist. I am licensed, I had to think about it, in the state of Michigan and Maryland. And I work with all populations, all walks of life, all types of people. So I spent the last 10 years in the prison system, so I've seen a few things.
Nice to have you, Keith. And I now hand it off to our moderator, Mr. C.R. Gibbs. C.R.
Welcome, everyone. My name is C.R. Gibbs. I'm an author, lecturer, and historian of the African diaspora. Let's begin. This question is directed to you all. Don't feel any pressure about answering it. If you don't think you should, how did your upbringing lend itself to you pursuing a path dedicated to mental health awareness and your decision to choose your current profession? Of course, I will pick now if necessary. But
I guess I'll go. So I guess I'll address the part of how did my upbringing kind of lend to this. I'll say that mental health was not discussed in my family at all. And I often find that it's not discussed in many families within the African-American community. We're starting to see a shift, but for me, the fact that there were a lack of discussions, it seemed as though there were some secrets that were not presented as a secret. They were just stories that were never told. And so I was a very inquisitive young woman, and I would ask a lot of questions and wouldn't get any answers. And so that kind of led me down this path of discovery, wanting to uncover what was kind of going on within my family system. And it just kind of lended me, like, the profession found me. I didn't find it. It found me through this, desire for discovery on the family system.
Anyone else a desire for familial discovery? Or did you choose it by a different path?
Yeah, I was smiling out of familiarity with the lack of discussion and just like sort of hearing things when grown folks were talking and kids were supposed to be in another room, but you walk by to maybe go get a glass of water, or you walk by to go to the bathroom and you hear something, and then you ask, and it's shut down. And so I think that's similarly just wondering, like, why did so and so act that way? Why were the relationships between certain family members the way that they were, and not really getting clear answers, and then learning years later, well into adulthood, oh, that's what happened. That's why so and so acted this way or that way. And so I always wondered what the motivating factor behind behavior was. And what I'm seeing now is, as particularly to my profession, is folks wanting to use more natural therapies to address some of the traumas that lives within their bodies. And so it just kind of followed me. Like, I wonder where that comes from. I wonder how that's manifesting, or why that's manifesting in your body the way that it is, and how can we address it? But similar roots, very, very similar roots.
Thank you. Anyone else?
For me, I grew up in a household where there was domestic violence, and not against my sister or I, but against my mom. And it was very, prevalent. I grew up in the 70s, and so in the 70s, there was not the rules and the policies that we have now. And so, we saw a lot growing up. And, my sister chose law. She's an attorney, and I chose social work. So, both came from a perspective of just wanting to help, and just feeling like always that there was not anyone to help us, or if there were, we didn't know about the services. And so then have just found myself as an advocate, and always, like speaking up for those that maybe, didn't have a voice or didn't feel that they could speak up for themselves. And so then, I feel like social work found me, or it's a call. I didn't necessarily know exactly which path I would take, but I just knew that I wanted to be a voice for people, wanted to be an advocate for people. And so, here I am.
Thanks a lot. Sister Deandra?
For me, I would say that I also came to the mental health profession through discovery. Growing up, my mother dealt with major depression, and I really didn't know that until I started to get into mental health. So it was something that was going on, and that as a highly sensitive person, I was picking up on and also internalizing growing up, but I didn't really understand what it was. I just knew that she needed something and that she needed help. And I would say that, when I started to explore my own mental health, and really as, in my angsty teen years, started to really see the manifestations of me picking up on her depression, I went to art as a way to escape, and I kind of created my own world and my own reality that I could go to and just forget about all of the emotional turmoil. And as I got older, I realized that, there were ways that I could help other people do the same thing. I became very passionate about it because I was also observing how other families, particularly Black families, had the same things going on, but they didn't have the words to describe it. They didn't have the support and mental health care. And so I really got invested in learning more about, like, why isn't this being taken care of? What are the barriers? And then just using art making to also help other people heal and to give them an avenue to express and find some safety.
Thanks a lot. Brother Jones.
You're on mute. You're on mute, Keith.
I said some profound stuff and we missed it all. So no, I'll go back. I'll go back. I'll go back. I said, like
Thank you, man.
like Leah said earlier, when I look at how I ended up in this field, I did not choose it. My undergraduate degree is actually in communications. I did public relations, radio, television, film. It was in a whole different genre. I did not even understand what all I knew social work to be was the ladies that came with the clipboard to take the kids away. That's what, growing up with one's perspective or one side of social work gave me as I grew up. But as I got older and I was in another job as a direct care worker and I had to work directly with social workers, I ended up as a receptionist for a private practice where I was around this all day while studying something different. In fact, for my master's degree, I tried to go into education. It didn't work out, and I'm glad because I belong. I'm where I should be. I don't feel I chose it. I feel I'm here, but I could not see myself doing anything differently. But as stated, I've seen different things with friends, with family growing up, and I always knew something was different about certain people or certain situation, or there was more to certain situations, or as alluded to, secrets. But I could not understand why certain people were treated differently in our family. They were kind of shunned. Some of the ones that had substance abuse or mental health issues. There were some issues there, but as I got older and I got into the field and I began to study and read and understand, it made a lot more sense of my family. It made a lot of sense of the world around me. And so I'm happy to be in the field, but I wake up every day realizing, especially on the days that it's crazy, I did not choose this.
Thank you very much. Does anyone else want to add to what we've heard so far? All right, then. Next question. What have you personally experienced or witnessed to help your clients overcome intergenerational trauma? Again, this is an open to all panel members that care to comment. What have you personally experienced or witnessed to help your clients overcome intergenerational trauma?
I'll go. For me, again, working with both juvenile and adult incarceration, I see a lot of generational trauma, and in that arena, I see fathers and sons who don't know each other on the outside, connected on the inside, which again creates a lot of dysfunction for a lot of the young men we work with, where most of their male role models and male figures who are incarcerated are away from home. So naturally, longing to be near them, they long to go where these men are. So when we see a system that is like a black hole, once you get in trouble, it's so easy to get in trouble and so hard to get out. But once we see these men getting in trouble and these young men gravitating toward the trouble that they see their fathers, their uncles, their grandfathers get into, it creates a cycle. And that cycle often leads to the next generation doing the same.
Okay. Anyone else?
I'll go.
Okay.
For me, with my work, my patient population is primarily comprised of Black women. And I do quite a bit of fertility support with naturopathic medicine and acupuncture. And what I have noticed in my years of doing this is that a little bit more recently, but a general theme overall with this particular patient population is that they're wanting to they're wanting to conceive so that they can do things differently. And so that is a recurring theme. I want to, and they say specifically, I want to break the cycle. I want to stop this trauma that I saw, in my mom, and that colored our relationship. I want to have a different relationship with my daughter. It stops with me. And so they're going through, because this is not my background, specifically working in mental health. I have a little bit of training. And so I do what I can to get information so that I can make appropriate referrals. And so I am constantly making referrals, understanding, how it lives within the body, how trauma lives within the body, and how that can impact all of the things that subsequently impact fertility. And so, but that is the recurring theme. I want to do something differently. This stops with me. And we're trying to unpack that. And so I'm doing my part, but I make it very clear that I have strong recommendations that they incorporate other kinds of professionals. I'm always recommending a mental health professional so that they can address that from the inside out.
All right. I'm sorry, go ahead.
I was going to say I am a social worker in the military, and what I've found, and I should say in my household, even though there was domestic violence in our household, the one thing that my mom did allow for my sister and I to do is to communicate our fears and to communicate, what we were feeling and how this was affecting us. And so what I've seen though in a lot of the patients that I see in the military is that a lot of people will, kind of gravitate to the military as a family to kind of escape a bad family. And so then, the first sergeant and the commander become mother and father, and our battle buddies become, brothers and sisters. And so it's a new surrogate family. And it can be a very beautiful thing. However, there's also lots of trauma that can happen in the military. And so then when I'm sitting with a patient, it's like trying to unpack everything, and so then if there's a deployment and there's trauma from that, and then you start to kind of peel back this onion, and the trauma started so long ago that sometimes, because some of the traumas that may be experienced, the reaction may not, you go, well, this maybe didn't necessarily warrant this response. However, it's the generation, it's the generational trauma again that they're reacting to. And unfortunately and fortunately, I feel like because we do have therapists in the military that I think for the most part, really good therapists, we can help individuals unpack it and try not to. The military is not necessarily the best place to escape trauma, because there's obviously more trauma, and so hopefully with those patients we're able to kind of help them unpack it and help them to heal so that they can continue to have a successful career in the military or choose not to.
Thanks you. Are there gender differences in terms of handling intergenerational trauma in the African American community? Again, the question is, are there gender differences? Anyone speak to that, please? Well, maybe we better get an amen on, first of all, are there gender differences? Then we can proceed from there. Have any of you witnessed, experienced in any way, gender differences in handling intergenerational trauma within the African American community?
I guess I would just kind of like to kind of bring it back just a little bit. When we're looking at trauma, one of the largest symptoms is avoidance. And I think that crosses, all lines regarding, gender. I think that it is the pain that's residing within the body that is like, on one end, it's inescapable, right? Because the body remembers, the body keeps the score of every single thing that it incurs. But then on the flip side of it, it is very easy as we present from day to day to avoid it and act like it doesn't exist, right? So there's this like complexity that happens within, that again, it doesn't know color, it doesn't know gender, it doesn't necessarily come about based upon one's age. It is all experiential and how one handles that. Now, if you want to try to break it down from my observation, I worked with Keith in a high secure facility with all males. And I would say it was probably 99.9% young Black males. And the way in which they would present is more through the lens of being volatile, right? Aggressive. We would know with them coming through the door that they were going to get either one of two diagnoses: ODD, oppositional defiant disorder, or CD, conduct disorder. We knew that right off the bat. Like, I didn't even need to look at their file to see what they were coming in with. And so I would say, yes, definitely you see this need to emote through one's behaviors, right? So more aggression in their presentation. I would say with women, women allow themselves to feel the emotion and not avoid it as much. Not saying that they don't, but we tend to be a little bit more sensitive with the things that are, you know, coming about. But I would also say that some of our women get very aggressive. Our girls are becoming, right, just like the young men, and not being able to articulate their thoughts and their feelings about the trauma that they are, you know, living within. And so as they, you know, grow, they become women that become very volatile. So I would say again, the avoidance that happens with trauma is the biggest thing, and it spans both genders, or all genders, because now we know that there are other genders that, or people who are non-binary, and you know, there's other ways of approaching this gender discussion. But I would say all human beings at large are dealing with a huge issue with avoidance.
Thank you. What barriers do you find exist most readily in the African American community, and how do those barriers create misconceptions about therapy and mental illness?
There's several. Going back just to touch on just avoidance, I personally, I believe that in dealing with a lot of the young men I dealt with or worked with, just overall as men, there's a barrier, one, and just even physical health. We're not often taught to govern our physical health. So mental health is even more challenging because that requires for men to be even more vulnerable, which sometimes is a process that is not passed down through generations. Fathers and grandfathers and great-grandfathers don't discuss feelings. They don't discuss how do you manage it. If you get hit, you get knocked down, no matter how bad you're bleeding or no matter how bad things are, get up and go on with life. And sometimes that's easier said than done. There are certain situations where you need help getting up. And so I see in working with all populations, again, trauma affects us all, but I think societally is dealt with, I feel a little differently when it comes to young men. I think we fail to take care of ourselves differently, and the support we are offered is not always, when we face a trauma, is not always seen as legitimate when we complain about it or we voice our concerns.
Anyone want to extend on that observation?
I'd like to also say that I think that there's just so much shaming that happens in our community. And so, you know, I mean, mental illness and what people had said about secrets. I feel like my mom grew up in a household with secrets, and you know, so that's that other intergenerational trauma that happens. Also, grew up in a household with domestic violence, and so then what she did different is, I mean, she chose someone that was also violent, but she did choose at least to allow for conversation about it. And I think that that is a lot of what happens in our community, is that there are just the secrets and the shame around it. And so then for mental illness, it's just almost like they would rather say that, oh, there's nothing wrong with this person, or either just to not discuss it at all, versus to be able to just to say that it is, you know, I don't think there's I do not believe that in our community that people see mental illness in the same way that they see diabetes or like, you know, hypertension. Like, you know, I mean, it's okay to have those, maybe even it's okay to even have alcoholism, but it is not okay to have depression or anxiety. You know, once you start having those, then you're crazy, versus that you just need help in the same way that you need physical help. And I see that as a barrier, that there's just been so much shaming around it that people will not verbalize the need for help.
Well, that comes to the subject of tools. And I'd like to ask you, what tools do you use specifically, and what have been the most successful tools to facilitate positive conversations about mental health with your clients?
I would say, you know, in my line of work, the majority of the folks that I'm seeing that have mental health issues that manifest as anxiety, manifest as GI disturbances, manifest as insomnia. That's what they're coming in, and they may not make the link between what they're experiencing, like their mental health and their physical health. As was stated, you know, there's a disconnect. Even though the majority of my patient population is women, I do have men in my practice as well, under my care as well, and there is this disconnect. So I spend quite a bit of time trying to help them make that connection between their mind and their body. That's not something that's reinforced in greater society, but it is one of the cornerstones of the medicine that I practice. And so we spend some time doing that. And acupuncture is a fantastic way of getting folks to actually be in their bodies, because they have to give me information about what they're feeling. And with some of the with some of the treatments that I employ, it allows them to actually like feel. You know, so I've had people report that they are actually feeling some anger that they have not been able to express, that they have specifically been pushing, you know, trying to suppress. They're actually feeling that. I've had folks, you know, they're lying on the table and they begin to cry because those things are coming through to the surface. And many folks will come in specifically requesting a particular kind of therapy that allows that to happen with acupuncture. So that's my primary tool. And more folks are seeking me out specifically because they're dealing with the manifestations of particularly their anxiety manifesting in physical form. And they've heard good things, or they want to see if it works because they've tried everything else and nothing has worked. And then once those things are coming up, I make some space for that. And then I go to my referral notebook and say, okay, this is a person that I think would be good for you to speak with, so they can continue to deal with those emotions that are coming up.
Thank you. Thank you. Anyone want to mention any other tools? Any feelings, for example, about meditation or?
Yeah, well, I was just gonna add that one of the largest tools is psychoeducation, right? Because coming into an office, whether it be virtually or physically, especially in the Black community, with this being a foreign act that we tend not to do, psychoeducation is necessary to assist them in what they are experiencing in their bodies, right? So being able, as Dr. McCarter was saying, to kind of connect the dots, science for some reason has disconnected the mind from the rest of the body. Why, I don't know, because the mind controls the body. And so being able to understand these are the physiological things that's happening within, and it is because of a bad thing that's happened to you in your past. Talking about what those things look like, showing visuals to be able to pinpoint and identify on the body, right, what you may be experiencing, what may be, right, bubbling up or manifesting within. So I believe that that is one key thing along with talk therapy. It's the thing. It allows you to put language to what has been a feeling, and then you can go ahead and emote from that point. But I would say those two pieces for sure.
Deandra, did you want to add your perspective?
Yeah, so I was going to say one of the practices and tools that I really use is, you mentioned meditation. So mindfulness, I feel like, is just such an important tool because, in my work, I'm really trying to get my clients in the here and now. We talked a little bit about, barriers to, the Black community, seeking mental health treatment. And I think one of those barriers is the belief systems that we have about mental health treatment, and those belief systems that are passed down through generations. And so, in the here and now, we can kind of challenge that, the beliefs that we once have, used to live by, that, if, we just pray, then everything is going to be okay. That you can also now pray and, seek therapy and seek help, but, even just the idea that, we have learned to say that we're okay when we're not okay. Really using the here and now to tap into the body and say, well, is your body telling you something different right now? What is really going on in this very moment? And so really using mindfulness in conjunction with art therapy too, because I think the visual, like you were saying, Leah, is really, really helpful. What I find is I'll even do like some body scans and give them, a piece of paper and a body outline where they can color within that and really notice where they're holding their tension, the parts of the body that, really they're feeling intensely. Maybe there's like a tingling or whatever that may be. The more they start to practice that, they're actually giving themselves the opportunity to be in the present moment and really focus on what's going on right here and now. So it's really the, vacillating between being in the present moment and also exploring intergenerational trauma and their own, trauma history to help them heal and to aid in the healing.
Wonderful, wonderful. I saw we were getting a little church in here with head bobbing and nodding. Come on, I know someone else wants to add their opinion or experience. Who wants to begin?
I will. I can go.
Mhm.
I will say psychoeducation for our community is very important. We have a lot of ways of thinking that we tend to pass down traditionally, that we don't get the help that we need. This is for mental health, this is for physical health. But we will go for some things physically. For diabetes, we'll go get help. For high blood pressure, we'll go get help. But for mental illness, we've been taught to keep that to ourselves. And a lot of times when, again, like anything else, when there are preventative measures that are taken care of early, we have better results. When we can figure out what's going on sooner than later, we get better results. I see this working with children. I find, because I work with both children and adults, many of the kids that I work with are more prone to want to try to do things to get through whatever has traumatized them. Whereas adults sometimes become so resistant, and they don't want to let you near their pain because they've been carrying it so long, and it's almost an object of theirs to protect at this point. So you have to start working with them to help them understand this is actually poisoning you. This is hurting you. So you have to, when you're ready, you have to start letting go. So I do see a difference in our community. I do see a difference in how we don't want to sometimes open certain boxes to alleviate that pain. But once it's done in a calculated measure, it was mentioned before, going to the right person, getting the right referrals. I've seen people who've needed medication to deal with the depression, deal with the anxiety. I've seen people who did not need the medication. They were able to find natural ways of managing their symptoms and their emotions. But it takes sitting down with a skilled therapist. Sometimes we don't talk about what we call secondary trauma, whereas we weren't directly impacted, but I've listened to people talk about, again, the abuse that has taken place with others around them, and it has impacted them greatly. We see that with a lot of the videos from the recurring videos of the shootings and of the other things that we've seen over the course of the last few years. We weren't there to witness it, but from seeing it over and over again, it re-traumatizes. So you're dealing with a population of people who have never set foot into some of these situations, but they have been traumatized as if they were.
Can I add to what Keith just said, like a couple of things? Because Keith, you just touched on, right, this viewing of traumatic situations. And when we look at our mental health Bible, the DSM-5, it will tell you that for PTSD, right, to actually check off the boxes to say that you received this diagnosis, that observation of the media does not qualify. That when we're talking about racial issues, right, in America, that's a race issue, because they don't have to see the salient images of their people dying continually before them. And so because of that, they don't have to acknowledge it, nor, right, qualify it in the diagnosis. And so that's one of the ways that Black people go undiagnosed and untreated, because their pain is not acknowledged. So I just kind of wanted to add to what Keith was saying there, but then kind of backing up and going to the church. I tell people all the time, it's okay to pay and pray. It is okay, because the shame that Dr. Hawkins was speaking about actually can get wrapped up in the prayer, because nobody hears the prayer, right? But you and God. But we also know that those of us that are trained, that being able to talk about allows for the pain, right, to come out. You have someone that's there to lead, guide, and direct. But what the church doesn't teach us is that God has appointed people for this type of healing. The Bible speaks of it. I just want to give this text, and I'm not going to read it. I'm going to give it so people can write it down, take it home, read, and then like ponder on this thing, right? The text is 1 Corinthians 12:28 for those that are Bible believers and church goers. And it speaks to God appointing people like us, healers, that are able to assist you through this journey so that you don't have to carry this baggage anymore. So I just kind of wanted to add that. I'm going to be quiet at this point.
Well, now don't jump to it too soon now. Is there anyone else?
I want to just say with what Leah was saying too, is the other part is that we minimize our pain. And I think this is very interesting, is that it seems to me that even, I mean, white America doesn't acknowledge the pain of African Americans. It's like we don't experience pain in the same way, or not, and there's no empathy for our pain. And I think that, it's kind of, it's become something that we've taken on, that our pain is not, it's not validated. We don't even validate it sometimes, and we certainly minimize it. And what you were saying, Leah, like, I mean, we have it. It's happening, but I think that, I mean, if it's a Black woman, you've been told you need to be strong because nobody cares. I mean, if you're a single parent or you're whatever, you're doing it all by yourself, do you have time to have pain? Do you have time to allow yourself to emote and have that? Because you got to do it all. And for our Black males, I mean, do you have time? Does anybody give you the space for your pain? And so I think that that's another issue in our community, is that we have the pain, but I would even say we don't allow ourselves, but we're not allowed to have it.
Thank you. Thank you very much. In that case, what do you find to be your client's biggest challenge in overcoming this kind of racism and trauma? Can you particularize it down to that extent, or we're easy if you want to make some generalizations, but the question is the degree of challenge is what I'm asking about. The highest hill, the longest hurdle. What do you see when you counsel your clients?
I think getting folks, recognizing that it's not a weakness, right? And so there's the assumption of guilt, and the blame is generally put on self. There's something that they did or didn't do. So there's that part. And then there's also the appearance of weakness by acknowledging it, that they have for themselves, and also that they fear they may get labeled as weak by family or community. And so that goes back to what Dr. Hawkins was saying about like the stigma, this trope that, the strong Black woman trope, the strong Black man trope that we carry around and we hold dear. It is kind of like a badge of honor to appear to be strong in the face of being completely broken down on every possible level, mentally, physically, emotionally. And so getting folks to the point where they can recognize the strength in acknowledging what has happened to them, and the strength that it takes to actually go through a process of getting the right people in place in order to help them to deal with it. That has been one of the challenges that I've faced, and again, why I encourage folks to have a team of people that they're working with, because my focus is going to be on, I have that component because of the nature of the medicine that I practice, making sure that folks have that connection, as I mentioned previously, but I don't have the level of skill that, Keith has, that Leah has, that Dr. Hawkins has. Like that's not my particular area of focus. So I need to make sure that they recognize I can get you to the point where you can recognize that this is something that you need to explore. And then you absolutely need to take that further with other people. But that recognition and that acknowledgement, it is okay that you're seeking help, and actually is going to be better for you in the long run on every possible level if you do. And it is absolutely not a sign of weakness that you're doing so.
Thanks a lot. Sister Deandra, I thought I saw you leaning in. So did you want to add a little something extra?
Yeah, just to add to Dr. McCarter, and this idea of like having, a community of help I think that in addition to that, you know, one of the things that I found that's most difficult for the particularly Black people that I work with is when they have, you know, sought help, whether voluntarily or involuntarily, they have gone back to these environments where, you know, those that are around them, their family, and the rest of their community aren't getting help. And so I think that, you know, one of the things I've noticed is it's very difficult for them to believe, one, that they are capable of change and that they're capable of healing, because they're looking at their community and they're not seeing that. And then also this, you know, idea that, you know, you know, we are responsible for our own healing. And at the same time, you know, it's very difficult to do this alone, especially when, you know, you're, you know, your whole life you've been living without, you know, taking care of your mental health. You know, when you start doing those things, you really do need as much support as possible. And so I think, you know, one of the things that has been really hard for some of my clients is finding community outside of treatment, because treatment is kind of like, it's kind of like a bubble sometimes, you know, and it, you know, they do start to integrate, you know, what they're learning in therapy and the other avenues that they're using to take care of their mental health. They start to integrate those things into their lives. But the community is where they spend most of their time. And so that's one of the things that I've found most difficult, is going back to the community and how do I still keep going on this path of healing while also, you know, being in a community that isn't necessarily on that same path as I am.
Well, keeping that sort of thought that you raised, I need to ask you all if you would speak to the impact of the pandemic on your clients. Going once, going twice.
Well, what I've seen with the impact, the pandemic has affected everyone differently. I've seen some who have been leveled, and when I say leveled, I mean they were left alone with their symptoms for so long and by themselves that they had to seek help, because the depression became so intense, the anxiety became so intense, various symptoms became so intense that it drove many people to come get help. However, or the reverse side of that coin is, or the flip side of that coin is, some became more isolated. Some became more able to adjust to living with the darkness, as some of my clients call it. They locked themselves in rooms, and it was hard. You couldn't go visit family. You could not go visit friends. Things were different from how we have known them to be. And it has been a very hard time, especially for my young people, the kids. They have had a hard time adjusting. It wasn't reported as much as it possibly should have been, but suicide rates amongst young people, or attempts, increased during that time, or during this pandemic time, or this time of pandemic, because these children a lot of them are cut off from friends, family, and even being in a house full of kids. Our society is different. Everyone's glued to a screen. So you're so close, but you're so far away. So I have had the opportunity to see different scenarios play out, but the pandemic overall has been very difficult on us. And what's hard for most people at large is even more complicated for us. So, but again, we have the mentality, which is not a bad mentality. We figure out a way to get through it. But as stated by Deandra, the help, coming together, working together, and it's something that it's part of us, and we need to do a better job, instead of the stigma and the shame that we kind of share.
Okay. Anyone, the impact of pandemic that you've personally seen on your clients?
Yeah, I would say too that domestic violence went through the roof as well. Right, there were a lot of, families crammed in spaces, some large, some small. No matter the size of your home, it was too much. It was overwhelming. And having to engage in, multiple tasks that one may not have had to do previously, that overwhelmed them, and they were agitated, right? They were irritable. They became very angry and resentful, and they would take it out on one another. So not just the children were suffering, but there were adults that had to be in space with individuals where maybe they could go to work, and that was a moment of reprieve. They had to actually coexist 24 hours a day. And that was very, very difficult on them. And like Keith said, it kind of just drove them. So we see an influx of the African-American community now seeking out therapy, whereas in before it wasn't, right? Churches are closed, so you have nowhere to go for community, for resolve and a measure of peace. And so the pandemic, although seen as something that was bad and disruptive, it was on one end, but it was also helpful in motivating individuals to try something new for their existence that they never felt strong enough to do in the past.
Thanks a lot. There is a miracle has occurred, and each of you will be president of the United States, and you will be able to create policy, if that's the approach that we need, in an effort to change society, to break down the stigma and break the power of intergenerational trauma. And so what two things, this is to each of you, you're the boss now. What would you enact? What would you encourage? What would you demand that this society do to better handle intergenerational trauma? Leah, Sister Leah, start with you. I'll throw you to the lions first. What would you do?
For all women, because again, this is an area that can be controlled. Sad that it's only imposed right on women, but we know that as a woman is pregnant, she has to go to the doctor, or she should go to the doctor to care for the fetus. At that time, she should also concurrently be enrolled into a program to deal with the mental health, right? And as you know, in concert with the physical health being maintained, because we know intergenerational trauma doesn't always begin once outside of the womb. We know with epigenetics that trauma can be in utero. So it would be awesome to have policy where the woman that is pregnant also be enrolled into a therapeutic program, whether it is a group program or it is individual. We got to start somewhere. And we have her go through this process so that when the baby is birthed and born, she has some skills and some tools that she could use to attach in a healthy manner with her child. We know that attachment is one of the biggest issues, or the lack thereof, with intergenerational trauma. So if we could build the attachment before the baby comes, then we have a better measure of success for our community in the long run.
Okay. Sister Latia, what do you think about that? If you're boss now, you're commander-in-chief, you're the combination, the head of all of the armed forces, what would you put in place? What changes would you make?
Wow, you put me on the spot, head of forces to my community. But, one of the things that we have done in the military in the past has like made mandatory mental health checks where everyone comes in and has to sit down with a therapist and, like tell us that they're okay. What I've seen is that doesn't work because, in that community, they don't want to be made to do this. But, and I think this is probably, with everyone. However, I would love to see access to mental health for everyone. And with the access, I would also just love for there to be more people who, look like us that actually really just talk about it. They talk about so like in the same way that we did with COVID, that there were so many individuals that said, hey, I got the vaccination. And, in our community, people that we could identify with and, say, okay, or like, if they got it, maybe I should get it, because they look like me or they're from my community. But not the famous people. They don't move people, I don't think. Common folk, the person that works at the grocery store, somebody that you respect in your community, someone that you can touch that says that I have had depression or I have, PTSD or, I have anxiety and I got help for it and look at, this kind of thing. I would love to have those kinds of regular people doing commercials and doing these kind of being in these places to be able to really have other people identify and say if they can do it and they can verbalize that they've been struggling, then then I can do it too. And then the second part is access to the services, and then just for the mental health side and the military and everywhere, more resources. So that is always an issue that we lack the resources that we need more social workers, we need more psychologists, we need more art therapists, we need more individuals to do this work so that when the people come, they have someone that can help.
Thanks a lot. Sister Sophia, you're the problem solver in chief.
Yeah, I think about time. So I think about two things. So insurance coverage for these services, expanding insurance coverage for services, expanding the number of visits that are allowed for therapies, mental health therapies, but also, like therapies like acupuncture. There are some really unfortunate limitations around that. And also I think about time and folks not taking time, not being able to take the time because they're not making a livable wage. So continuing to push for policy around, did I take yours, Keith? Did I? Pushing, for more policy and legislation around a livable wage so that folks can have the means and the time to be able to seek out the services that they need.
Thank you. Sister Deandra?
Okay, I have a couple. So, similar to what Dr. Hawkins was mentioning is I would create some sort of policy around planting mental health professionals in our communities and, really finding a way to focus on like community support. We all know about, several instances where, where unnecessary force was used on someone who was having a mental health crisis. And so being able to have people in the community not only can support that, but also just everyday situations where people can be building skills that are going to, help them succeed in life and really, work through their own intergenerational trauma, where it doesn't end up impacting the rest of their life in a negative way, but they're using it now as a way to, inform their goals and their future, with their families. I think having community support is so essential. And I would love to see, like teams of mental health professionals within each community, not just one person, but where there's houses of different individuals that are there to support the community. Another thing that I wanted to mention too was in terms of schooling, some sort of policy around providing more education on the true history of America, and also emotional intelligence. I think it's interesting how in the school system, we don't talk about the very things that we really need to succeed in life. We have all these math and science courses, and those are all important, but we really need to tie in ways that we can, our kids are in school more than they're at home. So if we can start working on, emotional intelligence at that time and just ways to manage and to cope with stress, I think school is a great place because they spend so much time there. And then the other thing that I wanted to mention was providing more mental health support within the prison system. And, there's a lot of issues and policies that need to change around that, but just mental health in general is overlooked with people that are incarcerated. And so really providing some additional support and even having more mental health professionals than, possibly, other workers, that the workers that are there all need to be trained, or at least to some degree trained in mental health.
Thanks a lot. Brother Jones, take us the rest of the way to the summit of the hill.
Keith, you're on mute.
And so that's why I said what I said. No, I'm joking. No, I'm joking. I make a lot of noises because I'm like, whoa, that was good. Like, and I had to mute myself because I don't want to distract from people speaking. But many of my suggestions have been stated, but I'll reiterate. First and foremost, we have to make mental health care accessible. By doing that, we have to make it affordable, Dr. Hawkins. So we have to also open the door for alternative types of medicine. Again, some people do respond differently. Everyone doesn't need the psychotropic drugs to maintain. So, but having that as an option would be amazing. So that's one of the things I would do. As far as education is concerned, I believe we should open up the curriculum of emotional intelligence at an early age, where we're teaching our young people how to manage their emotions. There's no way possible in this life that most of us will not face some form of trauma or some form of, or even just death and loss. That can be traumatic for a lot of people. But we're not taught how to grieve. We're not taught how to process these emotions. So I would change the school curriculum where that is something that we start working with our young people. We have a tendency to want to help them once the situation happens, or when they're in trouble. That's when we want to send them to therapy. But we sometimes see the signs of our kids doing things, or or they're not focused, or they're not present all the time. And we see certain things about our young people but we don't always know what to do. But it's not until they get in trouble that we want to send them for help. But if we were able to help them sometimes in some situations, because again, having worked with prisoners and people coming out and re-entering into the community, I've worked with the offenders, but I do enjoy working more, or just as much, with those who are what's the word that we use? They're at-risk youth. They haven't quite gotten in trouble yet, but they're on their way. But preventative work is where I think we have to get back to doing. it still matters to a lot of people. Some young people are going to make decisions. Some old people are going to make decisions. But I think generationally speaking, we have either, for a lot of reasons, we don't have the resources, we don't have the money, we don't have the, I can't remember the last time I've seen like a rec center or even a certain, well, because of COVID, I know certain things don't exist anymore, but even before COVID, we did not have access to certain programs that we once had. So I would also increase the number of people in the field, as stated, that look like us. Not saying that they cannot or will not get support from other groups, but there is sometimes, again, just having that cultural competency or that cultural understanding that comes with knowing. I don't relate to everybody who is Black and who is male, but can I relate to some things? Absolutely. They may look at the same video I see and feel, and feel something. And even if it's not exactly what I feel, if they watch another person executed on the through the media, there is a connection that people who are related to that or attached to that, there is an experience that they have that, just like I can never tell you what it's like to have to bear a child, but a mother who's had to bear down and push, they know that feeling. They know what it's like to go those months carrying that child. I can never experience that, but that doesn't mean that I can't help move her past the position of depression or anxiety. So I'm just kind of giving a premise of how you don't have to be in a situation, but you can help. But sometimes you do need someone who speaks the language, who understands the barriers. Again, working with the mass incarceration population, when they come out, that's all I did a lot of days, discharge or release plans. I knew that many of them were set up to fail before they even got home, unfortunately, because they were going back to situations, back to environments where they were not ready. So I know I've got to waver a little bit. There's so much I would want to change. And I know I would need to be president at least twice to get it all done.
Thank you. Listen, the day is far gone. It is time for us to fold our tents. I want to thank the panelists for their sagacious responses. They have shown themselves to be quite perspicacious, wise, and quite erudite. I thank you for your responses, and I turn it back over to Dr. Williams and to Lisa and put it in your hands. And again, on behalf of the panelists, thank you for your caring as well as your wisdom.
Yes, thank you, CR, as our extremely fantastic moderator. Thank you to Dr. Hawkins and Leah and Dr. McCarter and Keith and Deandra for your voices, your energy, your passion, your enthusiasm, just your heartfelt care, to CR's point, and concern for our people and our community as a whole. There were so many nuggets I have in my notes. I just wanted to highlight a couple of them as you focused on the fact that I thought was powerful, that oftentimes this career, this path found you, right? You were called to this place of help and care and concern. A focus on the fact that the barriers often that we find in our Black community are connected to the shame that is connected to mental health and the issues related to mental health, and those secrets, right, that we all have in our families, that we just don't talk about those things or those behaviors or so-and-so, those things that keep us from being free and being whole and healthy. Also, the very, very intentional need to connect mind and body. Again, didn't have the time to engage Resma Minikin's, my grandmother's hands, but there's definitely some synergy and alignment there with his words and the words that you all shared about the intentionality of connecting mind and body in this work. And then I'd like to also just kind of close on the fact that we need each other. To Deandra's point about community and the sense of being mindful of, this is not a journey we are expected or created to do alone, but it is a journey that we are to do together in community and in partnership and in fellowship. So with that, I don't have anything else to share. Lisa, did you want to close us out? Thank you.
Thank you, everybody, for sharing your insight, your expertise on this very important topic, mental health. And I want to thank our listeners for taking the time to listen to the discussion today. Have a great evening.
Thank you all. Take care.
Goodbye.
Bye-bye.
Thank you all.
Thank you.